Thank you. I had one for each, if that's okay. So in the first presentation, Sarah Segal from the Sowerby Foundation. In the first presentation, you looked at a lot of factors for the 4% take-up, I think, of GPs that were actively sharing and their patients were taking up use of looking at their own electronic records. Was one of the factors that you looked at the nature of the technology in use at the GP practice?
So that's a very good question. So the data that's available nationally essentially categorises practices into 0, 1 and 2, where 2 is fully functionally enabled and patients are accessing. 1 is enabled and patients aren't accessing. And we've dug deep and inquired, indeed, with NHS England and HSCIC as to the differences. They themselves say they don't understand that yet. So what we're actually embarking on is actually just phoning individual GP practices now to really understand what is going on at the ground level. Because I think there is a concern potentially, does the data actually represent what is going on? And if you look at it over time, you do see some strange trends. Some practices are switching from 1s to 2s and back from 2s to 1s occasionally. So what's driving this? Now, of course, some practices are closing, mergers, etc. But we need to understand a bit more. So yes, that's what we're doing at the moment, is actually physically picking up the phone and asking what's going on at a ground level.
And then just my other question, for the LEADS project, it was very great to see the feedback from the healthcare professionals. Have patients themselves been able to access the early trials? And if so, what do they say?
No, at the moment it's a clinical record that's being used by clinicians, so no.
Are there plans to make it patient accessible?
There are plans to do that, yeah. There are also plans around workflow, which is really important in terms of transferring information between parties, which will really actually open up the real opportunity.
Anybody else? Yep.
You mentioned, Phil Booth from Med Confidential. Obviously, Ripple is working. The single care record is working for direct care.
Yes.
And crossing the silos at the moment.
Yeah.
But you mentioned and spreading that best practice through Ripple, but you did mention research access, and has that been a part of the communication with patients when they've basically become involved? Because it's that sort of transition, if you like, from direct care to secondary uses that is, has caused problems in the past.
There's not been discussions about that because this is purely for direct care. I think the point I was making is, if it's not accessible to be able to transfer it between different areas of the country, then there's no even platform to enable that next step into research and analysis. So no, that's not in the frame at all.
To pick up, I think it's a very important point. I think we know, we've been told anyway, the National Information Board is looking to create a roadmap around that by April next year. But I think it's going to have to grapple with some quite disparate questions, because you said there's both the direct care issue, and consent for that might be more digestible. Then there's the research angle. Then there's the opt-in and opt-out, and then there's the safeguarding issues around all of that. So there's some very disparate questions which need to be answered, and I'm hoping that they will come up with some great recommendations.
Hi, I'm Viral Kantaria from the Department of Health. I work in mental health policy. Really interesting presentation about the work in Leeds. I just wanted to ask, how easy was it to get professionals from all of those local services on board? Was there a lot of sort of quarrelling involved? So I just thought, comparing that to Eric's slide where obviously the professionals didn't believe there were benefits, which I agree is quite worrying. So I just wanted to ask, was there actually appetite or coercion?
Yeah, I can tell you truthfully. So in terms of the acute, there was already that portal pulled together, and I think it was specifically based around A&E's access to make sure that they've got that at the point of urgent care. So I don't know about that aspect. In terms of GPs, there has been some challenge in terms of the view whether that's going to be something that is worthwhile to different GP surgeries, and there's been some discussions to make that, to bring that about. And as I've said, we're now at 104 out of 109, I think it is, so there's only 5 short of a full complement. So in terms of the slides earlier, it was quite interesting for me to see the comparison, because yes, there may be been some discussion in terms of corral, but we've got there. So people, I think the growing benefit is clinicians saying this is the benefit and selling it on to other people because they can see it.
Yeah.
So it's about that growing. I think that's why the ripple is the term that's being that's been chosen, really.
Can I just ask, I'm very struck by your only 44 patients out of 673,000 have opted out.
Yeah.
What did you do to enable that to happen? Or have people simply not opted out because they don't know they can?
Well, there's a detailed communications toolkit that GPs managed. So they had that whole debate within their GP surgery. So they've led and managed that because obviously they're the data controllers of that data. So they've handled all of that. And I think it's, as I said earlier, I think it's based on that trust relationship that a patient has with the GP that they rely on for their healthcare. So I think that's what's enabled that to be
and of
such a
your
success.
remaining 5 practices who aren't in,
Yeah.
are any of those sort of opposed in principle to the whole idea of this?
I think they're coming late to the table. Yeah. Not opposed, they're reticent, I should say, rather than opposed. I think.
Right. Because there are practices around the country that actively tell their patients they should have nothing to do with this, aren't there? I mean, there are.
But I think I mean that's not unique to healthcare. It's an issue we need to deal with. But we look across innovation, anything. There's always the early adopters, the people that follow rapidly, and then there's the laggards, for want of a better word, who then are slow to uptake. But eventually we get there. But you're right. So we need to.
But there's a difference between sort of laggards and slow adoption and active opposition. And there are practices.
Yeah, and I think it's very important because of course.
Do you not have those in Leeds?
I mean, I don't know the GPs. I'm from adult social care, bear in mind, so I couldn't really comment on the detail on some of that, to be honest.
Just a very final point. So the GPs were...
Sorry, could you just wait for the microphone? Sorry.
Just a very fine point. You say the GPs handled the interaction with the patients. Did they write individually to everyone on their list, or was it as people came into the practice, or was it leaflets and posters in the surgery and stuff?
It was a whole raft of things that were done. So it wasn't any one specific thing. It was like a whole toolkit, which was lots of different things, leaflets, conversations. So it was all sorts of things. Yeah. It wasn't just a single
So
dimension.
it sounds like you basically learnt from the summary care record experience and all that sort of stuff, other stuff. Yeah. Okay. Yeah. And of course Leeds is fairly unique in the country because of its sort of relationship to mothership. Yeah. So that could be interesting.
Hi, I'm Rose from Cancer Research UK. I think looking at the comments from staff particularly, it looks like there's some really great outcomes from it. One thing I did notice a few people saying that it reduced unnecessary visits to wards or unnecessary phone calls made. Do you think there's any risk that could lead to some patients potentially falling through the net if things weren't, kind of sometimes in terms of direct clinical things and sometimes maybe more a holistic view of how that patient's doing? Do you think that that's a potential risk, and are there any kind of mechanisms that you can add specific notes or kind of reduce that risk?
I think the integrated teams is the key where this is a real challenge, because what they've each got is their own information, and they're now working across as one team across that whole pathway. And I think what's been evidenced is instead of two people going on different visits for different purposes, they're having conversations and also using data that brings that together for the benefit of the person. So there are possibly risks if they would only look at that, but it's within the setting of an integrated team and working jointly as one full team around that individual. So it's only one small part of it. It's obviously not the only thing that they're doing.
I think actually there's more danger of that happening with the old style system, actually, than the system that you've described, to be honest. I think, reliance on letters, postal system, emails, phone call, texts, maybe none of those, I think things are more likely to fall through the cracks. Actually, where there's a system where the patients are helping and will help to centralise and will drive this sort of interoperability and full multidisciplinary approach to their care, I think it will be more holistic. And I think particularly about the survivorship issues, something very interesting for CRU UK, I think will be addressed much more wholly than the existing system.
They're just crying out for this. on a daily basis, you know, where they're coming to us, why can't we have information that's accessible to us? It's the kind of almost converse of the worry. You know, they're desperate to get hold of information, and having it, there's just some real comments there that say it's just transformed how I can actually operate in my job. So it's really eye-opening, actually.
Thank you. Luke Redman, East London. I think something like 40% of police call-outs have mental health or alcohol components to them. And I just wondered, either in the Sowerby work or in your direct work in Leeds, if you'd had any view on sharing it with services outside the traditional health and care boundaries, and how you're going about that, if you have.
I go back to my earlier comment about the roadmap for the consent here, and I agree. Ultimately, a whole systems consent-driven approach would be wonderful. I'm also very reflecting on what has happened before, and not turning people away. Think about what happened with CareDot's system. Yes, I think we should get there, but how we're going to navigate that, I think, will be very, very delicate. But ultimately, the benefits, I think, will be realised.
We're not doing anything on that. This is direct care. This is us making sure that we can deliver care for patients. So it's not about any of that. Not that engagement doesn't happen in those circumstances, but not electronically, not sharing data.
Yeah. Question in front here, Richard.
So Richard Smith from Patients Know Best. Do either of you have any evidence on the economics of all of this? Because you started off by saying we're under tremendous pressure. Part of this in the end is about using resources more efficiently. Is there much evidence?
Not to my knowledge at the moment, but that is one aspect of the work that we're doing over the next 12 months, part of the North West London evaluation. There is an economics aspect to that we'll be looking and answering that direct question.
I mean, what we're doing is we are constantly gathering, information, evidence of what we're doing. But obviously, it's difficult. You know, there's not an easy science really. But we are looking at what benefits we can prove economically.
Brian Fisher again. There is economic evidence around record access for patients. So if a third of a practice's patients were to access their records at least twice a year, the evidence is that there would be about 10% of appointments saved and hundreds of telephone calls. So people don't need to phone the practice. They very often don't need to go to the practice because they have the data, they understand the data, and they can just go about their business in other ways. So there is some evidence that it is very efficient and that it would really increase capacity in the system.
I'd be keen to see that, actually. Sorry, I missed that, but I'd be keen to see that. If you could pass on the details there.
Where does that come from? Is that UK data? Or?
Yes, it's UK data looking at the ridiculously nerdy detail of how much it actually costs for a practice to run a record access system, and then talking to patients about their experience of whether they could avoid appointments or not, or whether it increased the number of appointments they needed. Some patients increased appointments, but the vast majority avoided them.
My name's Kelsey. I'm from the Centre for Health Policy at Imperial. I just want to go back to the question asked about falling through the cracks. And one thing I'm wondering with electronic health records and digital systems, how do we optimise that for patients that might be quite a bit older or vulnerable groups that don't necessarily have access to tablets, apps all the time? If you have any comments.
Do you mean patient access?
Yeah. Patient access, yes, sorry.
Yeah. Mm-hmm. Well, we've not actually moved into patient access yet in terms of this digital care record. But what we are doing in Leeds is we're exploring citizen-driven health, where what we're looking at is if patients can hold their own information and that interacts into the system as opposed to the system and sharing that outwards, if you see what I mean. So where they've got their appointments, they've got a diary, they've got access, the wearables, the stuff that was on slides earlier, that data coming into the system. But it's really about that self-management approach. So that's some of the things that we're working on specifically.
I don't have the whole answer, but that is certainly one aspect, looking at, again, innovation technology to deliver data. The other thing I think we have to look at is the role of the carers here, because, of course, there is a vulnerable group who are dependent on relatives, friends as direct carers, and how we can, again, through the consent process, get them to engage in this process, because we're extending their normal role.
Isn't that something that is just changing rapidly over time? Each cohort of older people will be much more technology equipped.
Yeah, I was going to say,
a 93-year-old mother who uses email.
No, absolutely. And I haven't kicked back at the question. I say, but we have done some good old patient side of the street sort of surveys, and actually you'll be immensely surprised the uptake of technology in the older population. And yes, they are more than willing to engage, because actually for them it provides the opportunity of not having to travel huge distances on public transport et al. So yes, they do actually engage, and so I'm not sure it's a bigger problem as we potentially think it could be, but I still think there are some very vulnerable groups who I think we need to think about the role of carers. Yeah.
Another experience about that in response to that question. So there are at least two major groups where access is a problem. One, those who don't speak English, and the other are, I suppose, older people, which I guess would include me. Our experience is that there are workarounds. So people share their data with their families, and the families do the translation. And the classic story that I talk about is an older patient who had pins and passwords to their record but didn't have a computer at home, gave those details to her daughter, and her daughter was able to supervise her care from Australia because she could access it wherever she was. So there are lots of ways of managing it, but I agree it does encourage inequity to some degree, but that is likely to change over the next 5 years or so.
Good morning, Clive Thompson from Cerner. I'm just interested in your experience of what's happened obviously recently in the United States around the unintentional hacking of information, 25 million records, demographics, and in going back perhaps Julie's comment about consent, whether or not there's any perceived concerns or anxieties around how you might manage that as you endeavour to roll out some of the programmes you've been discussing this morning.
Well, that comes down to the fourth aspect of the consent roadmap around the safeguarding information, and I think obviously users, both from the clinical side and the patient side, would want to see a fair amount of reassurance that the systems are in place. Of course, people are always going to reflect on what's happened in the US, be it with Sony or the government or whatever, and I think that concern will always be there, but we're going to have to mitigate it as much as we can.
Obviously, cyber security and all that is very topical, and making sure that we protect the data from a security perspective is really important. I think one of the other comments that didn't come through on the slides is we have a break glass front end to the system, so that we make sure that all the audit trails and making sure who's accessed the data, that role-based access is in place, so only certain amounts of data, so a social worker won't see the whole of that clinical record because it may not be relevant to their role. So we've actually put a lot of those things in place to protect the items of data, so it's a bit more granular than just the record. So there's protection around roles and legitimate access, which we've actually put in the system as well.
Right, which is a kind of question and answer that leads us directly into the next session, I think, in a sense.
There you go.
So, could we thank you very much indeed to